This is a case evaluated by one of my fellows, where the patient omitted an important history of repeated ocular traumas. With the contralateral eye having total retinal detachment. An important zonular dialysis was neither visualized nor reported, nor was the chronic damage that this eye presented. Consequently, a toric lens was scheduled, and the appropriate precautions for a functional single eye with a history of trauma and posterior synechiae were not taken. During the capsulorhexis, there is a noticeable loss of zonular support in the nasal area, approximately 2 to 3 meridians. Hydrodissection is performed with great caution, as an eye like this can bring any surprise. A viscoelastic agent is used to provide support and prevent vitreous protrusion in that area. A horizontal phaco chop is performed without any issues, successfully fracturing the nucleus. However, after the fracture it seems like one of the heminucleus wants to drop. Breathe, you are in control, let's do this. Think and make important decisions such as lowering the intraocular pressure, reducing the aspiration flow, and using good phaco settings to try to retrieve the almost dropped fragment and move it to a safe area. It's important to use viscoelastic to make a tamponade to prevent vitreous prolapse so that we can manage the heminucleus. Once there is more space, bringing up the other heminucleus is a good idea for subsequently implanting a 3-piece lens in the sulcus. But first, everything needs to be cleaned very well with an anterior vitrectomy. Remember that during vitrectomy, you need to have a hermetic chamber to prevent the vitreous from escaping. In this case we have 2 areas of probable vitreous protrusion, the posterior rupture in the inferotemporal region and the zonular dialysis in the nasal area. Both areas need to be monitored to prevent vitreous prolapse. There is no red reflex because, due to the dialysis, the blue went to the vitreous and made the surgery even more fun. Now we can implant a 3-piece lens in the sulcus to use it as a barrier and safely remove the remaining hem nucleus without the risk of it dislocating posteriorly. And this is how we can avoid having to call our retinal friends, even if we experience an early capsular rupture. I like to use carbachol to constrict the pupil and check for any vitreous fibers extending toward the incisions. We learn from this case that a good preoperative evaluation and thorough questioning can prepare you better for cases like this, especially if it's a monocular patient.